As Erin mentioned, we're going to be talking about how we figure out how to use the various thyroid tests, particularly focusing on primary hypothyroidism. And before I begin the talk, I just want to put up my conflicts of interest. I have no relevant conflicts of interest to disclose with respect to this presentation. I do have research funding from public organizations where I do research studies on appropriate utilization of tests and medicines. And besides being a physician and receiving my payment from that, I do have a salary from the Therapeutics Initiative and UBC for my academic work. So the objectives for talk today is we're going to briefly review thyroid hormone physiology. And the reason we do that is because it helps us connect us with the testing and why we are using certain tests. We'll go in detail over the indications for different thyroid laboratory tests. And after we do that, we'll use a couple of case examples to see how we can apply those principles to sort of picking and choosing which tests we want to do and when for our patients. So why are we talking about this in the first place? Why are we talking about thyroid testing? Well, we're talking about it because thyroid function tests are actually one of the most ordered laboratory tests worldwide. In BC specifically, we just looked at the data a couple of weeks ago, and after complete blood count and electrolytes, thyroid function test, TSH specifically, was the third most commonly ordered test. And when we look at sort of the rates of this testing, the testing has continuously sort of been increasing over the last several years. We're doing this test quite frequently and increasing every year, even adjusting for population growth. And even though we're doing quite a bit of it, unfortunately, a lot of it is not well spent in terms of the cost associated with the testing. It's often done inappropriately. And there's a lot of variation in how it's used. And there's one study estimating that nearly a quarter of TSH tests that were done did not conform with the ordering guidelines. There's a test that was done, it was a 2-year cross-sectional observational study that had Canadian and UK data. And what it showed was that from the Canadian data, 36% of Canadian patients were getting a TSH test ordered, with the vast majority, 96% of tests returning normal. And moreover than that, those patients were then getting repeat tests, despite having normal TSH tests repeated within the same year. So this is when we start to really question the benefit that our testing is doing on these patients. So kind of having that, background in mind as to there's a lot of thyroid testing being done. Often it's not many times it's appropriately used, but often there's an element of overuse there. So that's why we want to launch a little bit into thinking about thyroid physiology, reviewing the indications of tests, and then seeing how we can appropriately utilize them. So this is my only slide on physiology, I promise. So why this is important is to remember that thyroid hormone and production of thyroid hormone is actually quite tightly regulated. And the reason is thyroid hormones are necessary. They're an essential hormone. You need that for development of nearly all human tissues and metabolic regulation of nearly all cells. And it's regulated by a loop along the hypothalamus, pituitary, and thyroid axis. The hypothalamus produces TRH, which is the thyrotropin releasing hormone. The TRH then acts on the anterior pituitary gland, and the anterior pituitary gland produces TSH, thyroid stimulating. The thyroid stimulating hormone then acts on the thyroid gland. The thyroid gland makes the hormones T4 and T3. Remember that the thyroid gland predominantly makes T4, but the more bioactive version is T3, and that conversion happens at the cellular level. And then these intracellular T3 levels go back and regulate TSH. So if you look at it, and just if you remember any one thing from this physiology talk, it would be think about TSH as being right in the middle. TSH is at the center. It's being regulated by TRH from the top and is being regulated by the hormones below. And hence, we can have and adopt a TSH-centric approach when we're interrogating and thinking about the function of thyroid hormone. So TSH very well represents how this axis is working and how our thyroid hormones are being produced. And in terms of terminology, so primary hypothyroidism, which is the topic of today's talk and what we're going to focus on, reflects a dysfunction at the level of the thyroid gland. And this is by far the most common form of hypothyroidism that we see clinically. Now, we can also have dysfunction of the anterior pituitary gland, called secondary hypothyroidism, or at the level of the hypothalamus, which is called tertiary hypothyroidism. And many of us will just sort of combine those tertiary and secondary hypothyroidism into one category as central causes of hypothyroidism. So clinically, it's helpful to think about primary hypothyroidism, which is the most common form of hypothyroidism, where the problem is at the level of the thyroid gland, and then central hypothyroidism, where the problem is more upstream at the level of the pituitary gland or the hypothalamus. And again, the much more common form is primary hypothyroidism, problem with the thyroid gland, and that's what we're going to be talking about more today. So in terms of epidemiology and risk factors of primary hypothyroidism, the most important thing that I want people to take away from the epidemiology of thyroid disease is that it's not very common. The actual incidence of overt hypothyroidism, when we look at meta-analyses from studies in the US and Europe across, it's actually less than 1%. So overt hypothyroidism is not very common. However, when you add overt hypothyroidism and subclinical hypothyroidism, a topic that we'll talk a little bit more about, it does add up and it can go between 4 to 9%, but still it's not a very common disease. And there are risk factors for hypothyroidism. So we can start to think about people who are older, men or women, people with personal or family history of thyroid disease, if they have other autoimmune diseases, history of neck irradiation or thyroid surgery, radioactive iodine ablation, if they're in medications that can be toxic to the thyroid gland, certain dietary factors, or genetic conditions. So there are risk factors that predispose people for hypothyroidism. The most complicated part that that clinicians deal with when we take a history for hypothyroidism is that hypothyroidism has a huge number of symptoms. It can affect nearly most systems in the body. There's the neurological and psychological part where there is impaired memory, cognitive dysfunction, slow speech, depression. The most common thing we see is, here is often fatigue and not feeling very well. They might get the dry, coarse hair, dry skin, hair loss, brittle nails. They can actually get some sensory issues as well, so reduced hearing. Very severe hypothyroidism can get the pleural effusions and shortness of breath from that, bradycardia. Sometimes I see that in the hospital when I work. They can get GI symptoms like constipation, reproductive symptoms such as heavy or irregular menstrual cycles. They can get muscle cramps, muscle and joint pain. So there's a huge host of symptoms that we can get because of hypothyroidism. And the point that I'm trying to make here is that it's very difficult to rely on history features alone to tell us what the diagnosis is. So this is a condition where testing becomes really important, both the application of tests as well as the interpretation of results. The one thing I will say is when I'm doing the history and getting the one thing I do try to really discern from the history and physical exam is if I am suspicious at any level for central cause of hypothyroidism. If there's something in the patient's history, if there's something in the physical exam that's sort of pushing me to think more about something going on in the hypothalamus or the pituitary gland, if there's symptoms or history of brain tumors, if there are medications that are associated with the more hypophysitis. So that is one thing on the history and physical I do try to keep my mind towards if this is going to lead towards, if this is pushing me to think about central causes. But for the most part, most patients will have symptoms that are non-specific and could be related to hypothyroidism. And then it becomes really important to really think about what test do I order and how am I going to interpret the results of the test. So when I think about thyroid test results, I think about a group of tests that I can do to interrogate the thyroid function, and then a group of tests that I will do to help identify the cause of thyroid dysfunction. So thyroid function can be checked by the tests, which are TSH, thyroid stimulating hormone, which is, as you'll remember, I mentioned was in the center of the feedback loop. It's sort of the best test that we can do to identify thyroid or interrogate thyroid function. But also, depending on the situation, the results, free T4 and free T3. So those are the tests that help me see about thyroid function. And then there's the thyroid antibody tests. And those antibody tests are done when I'm trying to figure out the cause of thyroid dysfunction. So we'll talk about those in more detail on the next slide here. So thyroid stimulating hormone, remember, it's the most commonly used thyroid test, and it should be the preferred test. The TSH is the preferred test for the initial investigation of suspected primary hypo or hyperthyroidism. So if you're thinking the dysfunction is the level of the gland, it could be high or it could be low. The test that you want to start with is the TSH test, because TSH is regulated both by the hypothalamus from the top as well as from the thyroid hormone. So it sort of best reflects at what stage your system is in. So it's helpful for diagnosis. It's also the test that is used and is sufficient in and of itself to monitor patients who are on levothyroxine monotherapy for primary hypothyroidism. So it's the preferred test for initial investigation, as well as the test for monitoring. It is not recommended as a screening test, so we shouldn't be doing it in patients where we're not questioning or they don't have symptoms of hypo or hyperthyroidism. And again, it's not useful for tests for central hypothyroidism because, of course, in central hypothyroidism, the TSH itself is a problem, and it's not now anymore a marker of how well the system's working. So then we measure free T4 in that case. Now, one thing to say is that in British Columbia, if you in the order set mark it as suspected hypo or hyperthyroidism, and you order TSH, a free T4 will be done automatically if the TSH is abnormal. So free T4 is used when your TSH is abnormal. So it's used for diagnostic confirmation. So if your TSH is high, it's going to be used as a a free T4 is done to see if there's actually hypothyroidism. If your TSH is suppressed, a free T4 is checked to see if it's high, suggestive of hyperthyroidism. So free T4 is done when you've confirmed that a TSH is abnormal, and it's used to monitor T4 supplementations in patients with central hypothyroidism. And in people with hyperthyroidism from Graves' disease, you can use it to assess severity of hyperthyroidism and maybe ongoing management of forms. It should not be used in initial testing for thyroid dysfunction, except when you're thinking about central causes. So this is something I spend a lot of time with my medical students and residents when I'm doing this teaching, is because I see that there's a tendency sometimes in our learners to order TSH, free T4, free T3 all at the same time when they're interrogating thyroid function. An important learning point here is that TSH alone is sufficient. If the TSH is abnormal, free T4 alone is sufficient in most of the time. Which then leads me to the next hormone, which is free T3. So actually, free T3 has very few actual indications when they should be used. So this is the time when you're suspicious for hyperthyroidism. Your TSH is suppressed, which is what you expect. Your T4 is not high, which is surprising. And then you would do a free T3 to help you confirm the diagnosis. But that's the only real indication for free T3. Otherwise, it shouldn't really be done very often. And this is sort of a pictographic view, and I really like this. It comes from the BC GPAC guidelines, and the link is here below, but kind of shows you how you should be thinking about ordering thyroid tests. And here you can see if the TSH levels is normal, it's within reference range, there really isn't any more follow-up testing that's required. And you review the clinical diagnosis and you think, well, it's probably not related to thyroid dysfunction, and maybe we need to think about other things. If the TSH level is high and you've said hypothyroidism suspected, free T4 is done. If the free T4 is normal, you're done again. You're thinking that we're gonna think about other causes, and we'll talk about that a bit more in detail. But in the free T4 is low, then you've confirmed hypothyroidism. When it's hyperthyroidism, TSH is suppressed. You're gonna do a free T4. If it's high, it's hyperthyroidism, and you're done. If free T4 is normal, that's not what you expected, then you would do a free T3. And if the free T3 is high, great, hyperthyroidism is confirmed. But if it's normal, then you'll think about other things, and we'll talk about that again in more detail. So this is sort of a nice schematic to think about a stepwise approach when you're interrogating thyroid function and what it means in different scenarios. So then the next panel of tests that we can think about are antibody tests. And really, there are kind of three main antibodies I think about when I'm thinking about causes of thyroid dysfunction. It's a very common one that people would have seen and ordered is thyroid peroxidase antibodies. So these are antibodies directed against the thyroid gland, and it's used for diagnosis of Hashimoto's thyroiditis, autoimmune thyroiditis, which is the #1 cause of primary hypothyroidism that we will see in our practice. An important point to note here is that if you have thyroid peroxidase antibodies, in somebody who has primary hypothyroidism. You know their hypothyroidism is from Hashimoto's thyroiditis. That's it. There's no need to follow these antibodies over time. There's no need to repeat titers. Just the one measurement is enough. TSH receptor antibodies, the second category, is used for diagnosis of Graves' disease. So this is done when somebody has known to be hyperthyroid based on the thyroid function test. And now we want to think about the causes for hyperthyroidism. And the TSH receptor antibodies helps us identify Graves' disease as a cause of hyperthyroidism in the patient. The last one here, the thyroglobulin, antithyroid globulin antibodies. Again, I've seen some people order that. And really important point here is it actually does nothing to help us investigate for thyroid autoimmunity. Thyroglobulin antibodies are actually tumor markers, and they're only specifically ordered and should be ordered to follow after somebody's gone through treatment for thyroid cancers like papillary or follicular thyroid cancer, and they want to see if the cancer is coming back. They order these thyroglobulin antibodies. So for most of us who are not managing thyroid cancer, not managing recurrence of it, well, there should really be no reason why we need to be checking or ordering thyroglobulin or antithyroglobulin antibodies. So with those sort of key principles in mind, we're going to start thinking about some cases to illustrate some of these principles. And after the cases, then we'll kind of open it up for discussion and question. So case one, this is a 40-year-old female who's coming to your clinic. She has symptoms of weight gain, constipation, fatigue, brittle nails, cold and cold. She was previously healthy. She's on no home medications. Physical exam is significant for dry skin with excoriations. She has thin hair. Her BMI is 27. What initial laboratory tests would you order to assess her thyroid function? And I'll give people just a couple of seconds to think about it, look through the answer, look through the choices, see what they would have picked before I tell you what I think I would have done, which is I would have clicked TSH only and then check the suspected hypothyroidism box. Now this patient, and I wasn't as explicit in history, but there was no cause to suspect secondary hypothyroidism or tertiary or any central causes. TSH testing was sufficient. If I was suspecting secondary hypothyroidism, I would have done a pre-T4 as well. Now, if you choose suspected hypothyroidism in BC on the standard outpatient lab requisition, they will do the TSH first. And then you don't have to go and order another test or ask the patient to go back and give another blood sample. On that same sample, the lab will automatically perform the free T4 and, if needed, the free T3. So this sort of applies for hyperthyroidism as well. So this is an important thing to remember. There's no reason to order sort of all three tests up front to save cost or time for the patient, because you can just sort of as long as you've indicated you suspect hyperthyroidism, the lab will sort of continue to do the reflex testing. So again, kind of going back to this guideline, this patient is coming in, we can just start with the TSH. We don't really need to do the other hormones at this time. So you order the TSH, suspected hypothyroidism in this patient. The TSH is elevated, which is something you thought would happen in this patient. It was at 11, and the lab automatically proceeds with testing for free T4, which, as you expect, is actually low at 8 picomoles per liter. So what's your next step in this patient's management? You can order antibodies, anti-TB antibodies to confirm diagnosis. You can order baseline free T3 before initiating therapy. You can start levothyroxine therapy and repeat TSH and free T4 in 2 weeks or in 6 weeks, or you can just start levothyroxine therapy and repeat TSH in 6 weeks. So again, my answer here would be that I would just start levothyroxine therapy and repeat TSH in 6 weeks. And I'll sort of walk through why I picked that answer. Based on lab testing, this patient has confirmed primary hypothyroidism. So I don't really need a free T3. It's not really going to help me, and it's probably only going to confuse the situation if it doesn't come exactly how as I sort of thought it would be. I know this patient's TSH is elevated, their free T4 is low. This is primary hypothyroidism. Anti-TB antibodies, I don't routinely do them in my patients with hypothyroidism because I know that Hashimoto's thyroiditis is going to be the most common cause of primary hypothyroidism. And unless it's not going to change my management decision, particularly for this female, I wouldn't necessarily do it. However, some people might want to do it for clinical clarity or for other reasons. And if that is true, and there are certain, and I haven't gone through that here, there are certain indications when it could be considered and might be helpful in deciding treatment. But either way, in this particular case, I wouldn't necessarily do it. If, however, somebody does choose to do it, knowing it is positive once establishing the diagnosis of Hashimoto's thyroiditis is enough, repeat testing is not necessary. The other thing is about when to recheck the TSH once you've started treatment. So it's really important to remember TSH values change slowly. And so it takes that little bit of time for the body and the axis to retitrate and respond to the levothyroxine therapy that's been started. So TSH testing, again, I've seen it sometimes be ordered, 1 or 2 weeks after starting treatment. You really should be waiting at least 6 weeks before you kind of get to see how the TSH has now responded to the initiation of treatment. Important point, it is not necessary or useful to follow the free T4, free T3 in patients who are on levothyroxine for primary hypothyroidism. Your TSH will be reflective enough of whether or not your levothyroxine supplementation dose is adequate. Sort of goes back to this algorithm. So this is a patient with hypothyroidism, high TSH, low free T4, hypothyroidism is confirmed. You just need to monitor TSH, not the free hormones, and wait at least 6 weeks after starting with treatment or changes in dose before retesting TSH. So in this particular patient, you initiate the patient in levothyroxine therapy. You repeat TSH in 6 weeks and it's in a good range. Patient's feeling well, her symptoms have improved. Now, assuming the patient continues to feel clinically euthyroid and hormone replacement therapy, how will you monitor her biochemical thyroid function? So we already talked about doing TSH is enough, but how much? Like every 6 weeks, 3 months, 6 months, or 12 months? So most people would actually say 12 months is sufficient. Once the TSH has normalized on treatment, checking it annually is sufficient. Now, things may change. Pregnancy, significant weight changes, they develop gastrointestinal disorders, which might affect how they absorb levothyroxine, food supplements, which can also affect those things. In that case, you might want to check it more frequently. Another important thing to remember is that TSH levels can actually vary quite a bit, 40 to 50%, depending on different times of the day. And the levels can be, can range quite a bit depending on whether you check it in the morning or check it closer to the evening. So we don't make much of the sort of changes as long as the TSH remains within the reference interval. We don't put too much weight into the fluctuations that occur within the reference interval, and that should not be used to guide levothyroxine dose adjustment. Now we're going to move to the next case, and we're going to look at a slightly different aspect of thyroid disorders here. So here you're seeing a 56-year-old male for an annual checkup. He has no active symptoms. His physical examination is unremarkable. Specifically from a thyroid function, what screening test would you use to assess that? You can do the TSH alone. You can do a TSH with thyroid ultrasound, TSH with the free hormones. You can do all of the above or none of the. And I think you're probably guessing at where I'm going to lead you here. Answer is none of the above. We have Canadian guidelines actually stating that routine thyroid testing is not recommended in asymptomatic patients. This guideline recommendation actually comes from the fact that there is no evidence whatsoever, like there's just no studies to see what the effect of routine thyroid testing screening is. So the guidelines then consider the risks of over-testing and over-treatment, and hence on the balance of that say you should really only test when you have patients with symptoms and signs consistent with thyroid disease. Or you could consider that in patients have very specific risk factors and non-specific clinical presentation. So those are the times when you should be thinking about thyroid testing, but it's not something we should be routinely screening in our patients. So you decide to not do any thyroid testing. However, unfortunately, this patient was admitted to hospital a few months ago for pneumonia, and he required a brief stay because he required supplemental oxygen. However, during his stay, he had a TSH done because he was confused as part of his maybe a bit delirious in hospital, and there's so many reasons for why TSH might have been done, but a TSH was done, and it was a little bit elevated at 6. He has no symptoms of hypothyroidism when you see him in clinic. How would you manage this patient? So you're dealing with this abnormally elevated at 6.0 TSH. Do you start them on therapy? Do you order and confirm with the free hormones? Do you repeat a level? Do you order the antibodies to help guide your answer, or none of the above? Again, they're all kind of tempting options, but my answer here would be to repeat the TSH level, because thyroid function tests should just not be performed in acutely ill or hospitalized patients. Your hypothalamus pituitary axis goes haywire when people are sick in hospital, and interrogating most hormones and hormone function at that time is usually not very helpful unless the patient is presenting with symptoms of thyroid disease. Like if they're admitted because they've developed severe hyperthyroidism, if they are hypothyroidism, that's a different story. But if they're admitted for something else like pneumonia, it's very common to see abnormal TSH values, and it's very hard to know what to make of it. If anything, we see a variety of abnormal TSH free hormone patterns in the hospital, and it doesn't necessarily mean that they actually have a primary thyroid function. Sometimes when the TSH values are really quite suppressed or very high, over 20, is then we consider a little bit more and then think about maybe there is an underlying element of primary hypothyroidism here. But for the most part, a lot of the minor sort of abnormalities that are picked up is very hard to interpret. So for this patient who's now, 3 months out of hospitalization, I would repeat the TSH at this time and see where we go from next. So you repeat a TSH level on this patient, and it's still elevated. It's 5.7. You do a follow-up free T4 as a part of the reflex testing, and it's normal at 15. The patient is asymptomatic and does not have any signs or symptoms of hypothyroidism. What is your next step in the management of this patient? So TSH is high, but free T4 is normal, and patient doesn't have too many symptoms. Do you initiate levothyroxine with the follow-up TSH? Do you initiate at a lower dose levothyroxine with follow-up TSH? You don't initiate any treatment, but follow-up TSH in 6 to 12 months. You order free T3, or you order the TPO antibodies to confirm diagnosis. Again, very, very tempting options here. So what I would do is probably nothing, and then follow up TSH in 6 to 12 months. And this is where we get into subclinical hypothyroidism. So subclinical hypothyroidism, exactly as this case suggests, is a clinical situation where your TSH is elevated, but your plasma free T4 is normal. And most of the time, these patients have either non-specific symptoms or no symptoms whatsoever. Now, when the TSH is quite high, so it's over 10, especially in younger patients, there are studies to show increased cardiovascular mortality risks, and it's actually very controversial as to what to do in those cases, because the evidence to show that treatment affects those clinical outcomes is sort of inadequate, but there is evidence to show that the higher TSH levels have these increased associations. So that part is, still controversial, and treatment can be considered. But in this gentleman whose TSH is less than 10, he has no symptoms, doesn't really have any indications for treatment. And many of the TSHs of these patients that are high will normalize as I follow them up without any intervention. So it's really important and you have to remember that thyroid overtreatment has also harms, including cognitive dysfunction, atrial fibrillation, and bone loss in postmenopausal women. So it's one of those things that you have to really think about in the context of the patient and the risks that they have. But Canadian guidelines and the British Medical Journal guidelines also sort of discourage thyroid hormone therapy for patients with subclinical hypothyroidism. And the only group sort of where we think about potentially treating is when they have a TSH that's greater than 10. And they're younger. So the other one important thing is as we get older, our TSH values sort of get older and older. So we tend to get over the reference interval, but it may not have any implications or bearing on our clinical health. So if they're over 70 years of age, we are okay with tolerating higher TSH levels as long as it's subclinical hypothyroidism. But when they're younger in age, people can consider treatment if the TSH rises above 10. Again, the evidence is sort of emerging and not clear, and it's something that's more of something that requires more discussion with the patient. And then this is the last case. Kind of going into a different angle here, which is a healthy 25-year-old female in your clinic. For her first antenatal appointment, she asks about screening for thyroid disease. What screening tests would you order to assess her thyroid function in pregnancy? TSH once, TSH in each trimester, TSH and free T4 once, or TSH free T4 each trimester, or none of the above. So this is where we're starting to wade into really an area where the evidence is quite murky, and it sort of have to really sift through it to see what one would do. I think my answer here would be none of the above, because the evidence is insufficient really to support universal screening for thyroid disease during pregnancy. So there had been earlier studies. So one I should say, when people have overt hypothyroidism, the evidence is super clear that you want to be treating their thyroid disease completely to prevent any complications. But subclinical hypothyroidism, screening for hypothyroidism, is its own sort of area, because while earlier studies had showed that even subclinical hypothyroidism during pregnancy might increase adverse pregnancy outcomes, however, they showed that treatment doesn't really show any benefit in randomized clinical trials. And then meta-analysis of 3 randomized trials in women with subclinical hypothyroidism found no evidence for benefits of levothyroxine therapy. And in fact, more recent studies are showing that the current pattern of thyroid testing in pregnant women is contributing to overdiagnosis of hypothyroidism and overtreatment, which actually can lead to increased harms such as preterm labor. So universal screening for thyroid dysfunction in pregnancy doesn't really have a lot of evidence. Canadian guidelines and the BC guidelines basically suggest that you consider that in women that are high risk for thyroid disease. So women who are older, they actually say women over the age of 30, if they have known thyroid risk factors for thyroid conditions, then you could consider if they are known positive for anti-TPO antibodies. So there's risk factors. This is where you want to consider and test, but there's actually not enough evidence to show that we should be screening with it for thyroid for everyone in pregnancy. Now that is again separate. If they're known hypothyroidism, if they're overt hypothyroidism, clear, good evidence that we should be absolutely treating those to target. So just summarizing the key recommendations that we talked about, routine thyroid function testing is not recommended in asymptomatic adult patients. Use a TSH-centered approach, both for diagnosis as well as for following patients on treatment for primary hypothyroidism. If the initial TSH result is normal, repeat testing is not needed. Measurement of free T3 is rarely indicated in cases of suspected thyroid dysfunction. It's a very small minority of when you're suspecting hyperthyroidism and your TSH and your free T4 disconcordant. In hospitalized patients, unless thyroid disease is a suspected cause of the clinical presentation, testing should not be performed during acute illness, and that there's insufficient evidence to support universal screening for thyroid disease in pregnancy. There are some additional educational resources on this topic. So the therapeutics letter has been published on thyroid testing and primary hypothyroidism, which is freely available through our website. We've also worked with the CPD program at UBC to develop a module on navigating hypothyroidism, which is also freely available. And if any of you want to look at that, you can go ahead. In addition, we also have a portrait for practitioners in BC where you get to see how many of your patients had sort of repeat normal TSH done. So, patients with 2 normal TSH tests within the year, 3 normal and 4 normal. Sorry, this is an empty portrait, so it doesn't have any data for privacy purposes, but you'll be able to see how much redundant thyroid testing is happening in your practice as well. One thing that is important is speaking with patients regarding thyroid testing. We understand that there's a lot of external influences as well when it comes to asking questions about thyroid testing. So we worked with patient partners and with other providers to develop with Therapeutics Initiative and understanding thyroid test patients guide. So it sort of goes through for the patients what the different tests are about, why some certain tests might be ordered. So TSH test, T3, T4 antibody. And then it goes through a lot of frequently answered questions as to what if my thyroid tests are not normal, and are there any harms of getting a thyroid blood test or testing too often? So we try to go through these questions with our patients as well, so that they understand exactly why or why not we're ordering some tests. In terms of acknowledgements of a ton of people who contributed towards developing these educational resources and modules and that are mentioned on the left. And then we had substantial support from the UBC CPD for the instructional design and illustration of the educational module, and funding from UBC Faculty of Medicine for actually developing this module and sort of putting our heads together to work on this area. With that, happy to take any questions.
Thanks, Anshula. Wonderful presentation and lots of time for questions. There's a bunch I have to go through, so I'm going to go through them one after the other, except because I'm the moderator, I'm going to ask my question first. So my question is, when you looked at the portrait, so for BC prescribers, would you be able to summarize what the biggest issue was with BC prescribers in terms of repeat TSH testing? Like, is there a specific problem that we need to focus on?
Yeah, it's a great question, Aaron. I think the reason we focused on redundant testing is when we looked at the data in BC, we saw that there were 6,000 primary care providers in BC who had 10 or more patients individually in their practice who had 2, 3 normal TSH tests within a year.
Mm.
So what we identified, this is a widespread problem. And again, there's a lot going on with it, which is systems connectivity issues, EMRs not talking to each other, stuff like that,
Mhm,
which makes it hard to see previous results. But what
mhm,
we saw was that there's a lot of sort of testing and retesting, even though the values were normal or continue to stay normal, that were happening. So that's why we focus on this portrait, was just trying to people to get a sense of, this patient had a lot of normal TSH done. And that's why we
mm.
focus on normal, because if it's abnormal, clearly they need more.
Okay, great. Thank you for that. Okay, so let's get into the questions. The first one is, in the studies that you referred to in your earlier slides, was repeat testing usually the same provider or done does one see retesting done by multiple providers where prior results are often not consulted? So you sort of touched on that with inability to see what's happening
Oh, in
in
the
BC.
portrait though, we do make sure it's your test. So
Okay,
we won't be attributing tests that were done by somebody else to yours. So
okay,
the portrait, it would be your test.
yeah,
But absolutely on a systems level, this is because of fragmentation in our healthcare and multiple providers. So definitely compounds the problem.
okay, great. The next question, rates of testing were for all ages. So in the studies looking at the prevalence of over testing or testing, does it apply to older ages? Is best practice to only test if older than 60, if screening normal populations without the risk factors mentioned?
Actually, it's interesting because as one gets older, the TSH tends to rise. So you're more likely to get people that don't actually have thyroid dysfunction, but it's looking like they do. So
Mm,
there's not really an age-specific recommendation of when to screen or when to look. It's really just a recommendation that we shouldn't even be ordering it unless we thought that they have symptoms that could be attributed to thyroid dysfunction. We recognize the symptoms are vague, so it is sometimes still ordered, but in that case, just starting with the TSH, and if it's within the reference range, stop and not doing much more than that.
okay. So no screening for normal populations without risk factors.
Yeah,
Got it, regardless of age.
regardless of it.
Okay. What are your thoughts about impairment in T4 conversion to active T3 requiring T3 supplementation? How common or rare is this? And when do you suspect this might be occurring?
Yeah, that's a great question. And I will first and foremost say that my own experience with that is low. It's not a common thing that I've seen. Doesn't mean that it's not
Mm,
doesn't happen. I've certainly spoken to endocrinologists. So one of the planning committee members is an endocrinologist who sees that in her practice, where the addition of the T3 helps when somebody who's just not been responding or feeling well with that.
mhm.
Typically, before I start like adding T3, I will have at least a consultation with endocrinology before I get there. So I haven't seen it very commonly in my practice. And typically, if I'm going in that direction, I am at least having a phone consultation with endocrinology.
Okay, thank you. What would you do if you inherit a patient with thyroid antibodies with a normal TSH and free T4? Would you do regular TSH monitoring?
Oh, what a great question. Actually, it happened to me. This is exactly what happened to me. I did inherit a patient who had seen an internist 10 years ago with positive anti-TPO antibodies, and she was told eventually it's gonna fail and you're gonna get it. And she was getting her TSH checked. And I saw her 10 years from that first experience, her TSH was still fine.
Mm,
So clearly it doesn't happen. I think the rate they say is somewhere between 2 to 4% for subclinical
mhm,
hypothyroidism to develop. So
mhm,
I think it is reasonable to do a TSH because they're a risk for it. One thing I will say is, no, going back, it's helpful to have never done the antibody test in the first place. But of course, if you married the patient that way, there's not much more you can do. But
Yeah.
sometimes I also tell the patient, like, if your symptoms are fine and that, maybe we can just do it once every 2 years or something and just try
Mm.
to get them off that. So it's something that stays on their mind and they want to think about it. So I end up doing some testing, but I do try to have them focus on the fact that it's their symptoms that should be the more telling feature.
What about retesting TSH after starting a female with hypothyroidism on replacement on hormone therapy for menopausal symptoms? Would you recommend that or not?
After starting somebody on levothyroxine for menopausal symptoms? Or
Yes. So there's another question related to this. Some perimenopausal patients I inherited are on levothyroxine, no diagnosis of hypothyroidism, and this keeps their TSH quite suppressed, which helps them with their metabolism and fatigue. Metabolism in quotes. They are well aware of the risks, but insist on continuing levothyroxine. Is this reasonable to continue?
that's actually a very good question. I will say we're kind of totally waiting outside of the evidence-based zone here and going into conjecture zone. I have seen that, and that's why I was pausing because I don't know of any
Hmm.
off the top of my head, again, not directly related to that. I will say that again, speaking to endocrinologists, it's not as easy. If somebody has been on levothyroxine, it's not as easy. I'm going to just stop it today and you're done because you don't need it or your TSH has been normal in the past. It becomes quite, there is a degree that you've now impacted on the hypothalamus pituitary axis by now having this exogenous source of thyroid hormone going there and whether or not your gland will kick up depending on how long they've stayed on thyroid hormone. So I think
Hmm.
my key thing would be if somebody has been on levothyroxine therapy for now that you look back and you're like the indication wasn't clear, if they understand their risks and want to stay on it, it's probably at that point what I would just continue doing. But
Okay.
if they want to continue to stay off it, this is again, I've had to sometimes refer or talk to endocrinology about how can one, or if it's even possible to deprescribe when
Mm.
somebody's been on long-term levothyroxine therapy. And now you go back and look and say the indication wasn't right. So it becomes a bit of a harder situation when they've been on long-term therapy. And if they want to stay and continue, that is
Mhm.
probably the way to go. If they want to try discontinuing, I had one patient who actually was taking it for not a clear indication and actually ran out of the prescription during COVID and stopped taking it and was off it for 6 months and feeling fine. So then I was like,
Mm.
well, this is great. It happened. Clearly, you're fine. Let's stop it. But I think it
Okay.
kind of probably requires a discussion to really deprescribe it.
Sure. So I think you've addressed this, but I'll just ask the question again. This question came in before you addressed the subclinical hypothyroidism, but what to do if the initial TSH is high but free T4 is normal? How frequently should we monitor TSH after that?
Good question. The guidelines here say 6 to 12 months,
Hmm.
depending on the patient's symptoms. Sometimes I've noticed the TSH will normalize after the second time, then I go back and stop monitoring.
Hmm.
But if yeah, like initial after that initial TSH is abnormal, 6 to 12 months, depending how your patient's doing.
Okay. Next question. First presentation of thyroid nodules. If absent of any other symptoms, do you recommend testing TSH as part of the workup?
If there's no symptoms, because what you want to see if the nodule is functioning or not, that's the question, right? If the nodule is contributing to hyperthyroid symptoms. So if the patient doesn't have any symptoms of hyperthyroidism,
Hmm.
it probably wouldn't be high value. But this is something I would have to look back at the guidelines again just to.
Hmm. Okay. You have a 65-year-old male with severe fatigability and loss of eyebrow hair, but normal TSH. Would you do further testing?
I would probably then look for other causes because if
Mm,
it's 65-year-old, normally I would expect a TSH to be on the higher end. So if the
mm,
TSH is in the normal range, it would actually make me think that there's probably something else going on.
okay. We talked to the next question is about that perimenopausal patient. We addressed that. Would you treat someone with subclinical hypothyroidism value, and when you screen for symptoms, they say yes to fatigue? Everyone says yes to fatigue.
Yeah, usually, yeah, if it's just for fatigue, I wouldn't typically treat for subclinical. It'd be very unusual for me to treat anybody with subclinical. There's these very unusual cases. They're pregnant or planning pregnancy, they're anti-TPO positive. There's just lots going on, and then it
Mhm.
becomes more of a potential, but it's very unusual for somebody to get treated just based on fatigue for subclinical.
Okay. We have, I think, about 10 more questions and about 9 more minutes, so this will be the rapid fire section. What percentage, if any, of confirmed Hashimoto hypothyroidism are ever weaned off thyroxine?
None, I don't know of the literature, but none that I've ever seen. Yeah.
Okay. Do people with other types of autoimmune diseases, example diabetes, arthritis, psoriasis, benefit from yearly TSH screening?
It's a good question. So those are included as risk factors, and so it would not constitute as screening as more sort of case finding in somebody who has risk factors. So
Okay.
it's possible. It makes sense that you might want to do it more in that group.
So yearly?
Potentially, depending, yeah, on their symptoms.
Okay. I've inherited Hashimoto's patients who insist they require desiccated thyroid rather than levothyroxine. Do you have any comments on that?
So that sort of relates to the first question because desiccated thyroid is both T4 and T3. And
Hmm.
that comes back to the question of do they have an inability? Because remember we said that T4 has to be converted at the cellular level to T3 to be activated.
Yeah.
So the question then becomes, is it that group of people? Are they just people who believe in desiccated thyroid because of sort of, how they're conditioned to believe? Or is it that small subgroup of people who truly benefit from that additional T3 part. So that becomes hard to sort of separate if they are, in the normal range for TSH, despite being and T4 for despite being on desiccated thyroid and they're feeling okay, I might not do much. But if I really feel like they're getting too hyperthyroid, which I've seen the TSH is too suppressed, then I
Mm,
will start to have a discussion with them and sometimes getting an endocrinology involved just to sort of reassure them that let's try and just have you on levothyroxine monotherapy and see. But the main distinguishing feature here is to make sure that they're not that small subgroup of people that people are starting to think that they can't convert it.
mm, okay. Would it be reasonable to order TPO antibodies in patients with subclinical hypothyroidism to determine if they are in the early stages of Hashimoto's and are at risk of further deterioration?
Yeah, it is actually something that is suggested by many experts is, if you're subclinical, they will use the TPO antibody positivity, particularly in pregnancy, to like decide whether or not they should treat. But even outside of it, it
Mm,
is it's not an approach that's ever been sort of studied, so it's hard to comment on the evidence, but is it a reasonable approach? Yes, it kind of tells you and the patient that, there's a higher risk of this developing, and perhaps you do want to keep a closer eye on it.
okay, thanks. A lot of patients admitted to hospital with arrhythmias get a TSH sometime multiple times. If recurrent problem is this necessary if previous results are normal and there's no other changes?
There's way too much TSH testing and repeating in hospitals. So I totally agree with that. Now, there are times when I've picked up somebody with a new AFib, and it's actually because they're newly hyperthyroid. So I would
Mhm.
definitely do that one test to make sure that it's not that, but definitely no value in repeating it. And if it was done very recently and they've had the arrhythmia preceding that, then I wouldn't repeat it.
Okay. What would you say to a patient who wants to replace T4 with porcine T4 from a natural product store?
My approach to that person is that we've studied levothyroxine. We know how much dose, we know how much to dose, we know how to monitor, we know what's going in there, and we have a lot of safety data with it. When you do this other piece, you don't exactly know. It becomes harder to monitor because there can be varying amounts of active levothyroxine in there. And
Hmm.
that makes it a bit more challenging. Your symptoms may not be as stable over time. We might have to do more testing to see and monitoring. So that's sort of what I tell them is levothyroxine, we know what's going in there, we have safety data, and it's much easier to monitor and predictable.
Okay. Earlier, I asked you a question about that person on hormone therapy for menopausal symptoms, and I misspoke. Person's clarified that the patient is on levothyroxine already and then menopausal symptoms and wants to start estrogen therapy. What is the role of TSH monitoring in that setting?
Oh, good question. I have to say, I don't know if there's any difference. And if there is, I would have to look into that. I'm not sure that it would change the monitoring. And if it does, then it's probably something that I just haven't come across yet.
Okay. I've heard that iodine deficiency is becoming more prevalent as people are not always consuming salt with iodine. or iodine. Is hypothyroidism due to this becoming more common in North America?
I haven't seen that very much, but actually I did see some recent data showing that there's more iodine deficiency related hypothyroidism in BC compared to other places in Canada. So perhaps there is an element of truth to when people are picking the products and unwittingly sort of losing out on some essential nutrients.
Okay. Are there hormone supplements patients could be taking that we should be asking about because of safety risks, I guess in the context of thyroid disorders?
Yeah, I mean, it's a whole long list of things that can have a desiccated thyroid or elements of it. Most of the time, I will, when I'm taking on a new patient, is ask them to supply me the names of all the natural products they are, and then help work with the pharmacist to see exactly what's in there so that I know it's a very time-taking, consuming process, but it's very difficult. And there's a point when they're taking so much that I say, I don't even know what you're taking anymore. Like the
Sure.
liver enzymes are abnormal, it's hard to predict.
Do you typically increase the dose of replacement therapy for women with hypothyroidism who become pregnant, and by how much?
Yes, it is a recommendation to increase the dose. There are trimester-specific TSH targets, so
Mhm.
one has to target that, and I would have to confirm. I believe it's somewhere between 25 to 50% increase of the levothyroxine dose to keep to meet the TSH trimester-specific targets.
Great. So we got through all the questions. Anshula, thank you so much for this very practical and useful webinar.